Hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series. And thank you for participating. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. Ashley has added our chat waterfall, some questions we would like for you to answer. And then also today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHU's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom tomorrow. You can also visit NAHU's resource page on the website to find this resource and view the past sessions. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. If there is time and you would like to ask your question live, please raise your virtual hand and I will open the line so that you can speak. So just some background on NAHU for those who are not familiar with us. We are a membership organization of 8 regional and 2 national AIDS education training centers, also known as the AETCs. Established in 2010, NAHU supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHU has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance using disorders through the provision of locally designed education and training. Visit the website to submit a technical assistance request, read case studies, see featured resources, and check out upcoming ORN events and trainings, learn about ORN work groups addressing health disparities, and more. So we value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session, and it will also be included in the post-webinar email. So we ask that you complete it within the next 2 weeks. If you are requesting continuing education credit or a certificate of attendance, you will need to complete the evaluation. To receive contact hours for participating in this CE program, you must join the webinar, attend at least 60% of the presentation, and complete and submit the electronic evaluation. So you will receive your requested certificate within 3 weeks of submission of the evaluation. So at this time, I would like to introduce today's speaker. Dr. Nika Seidman is an OBGYN and an associate professor at the University of California, San Francisco. She completed fellowships in family planning and reproductive infectious disease with a focus on HIV care and prevention for women. She later co-founded Team Lily, a multidisciplinary care team for pregnant people experiencing homelessness, substance use disorder, and significant mental illness, which is based out of San Francisco General Hospital. So with that said, I am happy to pass it over to Dr. Seidman.
Okay, good morning, everyone, and good afternoon for people who are on the East Coast. Thank you for giving me a moment to bring up my slides. And thank you especially so much for joining this Friday in what for many people is a busy summer and a very hot day. I hope you are staying cool and healthy and safe. My name is Nika Seidman. Thank you so much for that kind introduction, Liz. And I really want to appreciate Liz and Ashley for inviting me today, and especially for their help and patience with getting this together. As Liz mentioned, I am an OBGYN based at San Francisco General Hospital. My pronouns are she and her. And I'm going to be talking today about trying to bridge some of the silos between HIV prevention, substance use disorder, and pregnancy care. I this is a topic that is a long-time passion of mine. Just for my background, as I said, I'm a generalist OBGYN. I did fellowships in family planning, as well as reproductive infectious disease with a focus on HIV care for people of reproductive age and who are capable of reproduction. And I really believe that we have so much work to do in terms of breaking down silos in this arena. So I look forward to talking about some of the approaches to that today, and especially to your questions and comments at the end, because I learn as much from these webinars as I hope you do from me, and I really look forward to the conversation and discussion because we have so much work to do. So with that, I have no disclosures. And the way I was going to approach this talk today is a little bit different from the ways I usually do talks. I am going to hopefully tell more of a story that talks about how we came to found the program that I work at, Team Lily. And the reason I wanted to talk about that is because the goal of our program is really to break down those silos I just mentioned between reproductive health, HIV care and prevention, substance use treatment, and also, especially relevant here in San Francisco, other barriers to care like experiencing homelessness, significant mental illness. Our program is infused with principles from the long history of the way that HIV care providers and advocates have approached, in particular, HIV care in pregnancy. And also we have learned a ton from advocates and clinicians and affected individuals from the work around providing healthcare for people experiencing homelessness. And finally, tons of appreciation and learning from the harm reduction community that we've tried to infuse into our work. So I'll try to kind of talk about how each of those affected the way that we provide care. And then I hope to talk more about how specifically we can offer HIV prevention in the setting of substance use disorders, as well as thinking about how to provide HIV treatment in the setting of substance use disorders. And then finally, woven throughout those, I hope to provide a couple of client stories that have really impacted me and the way I think about these silos of our care and how we can do better for our patients and clients. And just to say, we're going to do questions at the end. So please write down your questions, put them in the chat so we can discuss them. I'm going to talk for, let's see, it's up for about 40-ish minutes. And then I hope we'll have plenty of time for questions. So to start, I want to go back over 10 years to when I was working at HIV, which is our perinatal center for care of people living with HIV and who are pregnant or postpartum. And I met very early in 2013 two people who really made me think a lot about the way we provide care, both the strengths and the challenges. So the first story is about the patient on the left. This patient was a HIV patient. She was living with HIV. This was her sixth pregnancy. She unfortunately was not as engaged in care between pregnancies, but always was able to really get into care during pregnancy. And for the past few years, she had gone to ERs, urgent cares, primary care with this back pain that just, people had given her braces, people had given her lotions and potions and all kinds of referrals to PT, and it just would not get better. And she was so worried about it. She got pregnant. We did an exam and very quickly noticed that her exam was very abnormal and her spleen was incredibly large. And she had quite advanced lymphoma. We were able to start chemotherapy in pregnancy. She was that sick. And she did terrific. And what she said to me was that pregnancy saved my life. And that was really telling to me. I am an obstetrician. I very rarely hear people saying that pregnancy saved my life. And I've carried that kind of messaging with me in particular, as I've worked with people with substance use disorders and experiencing homelessness in San Francisco, because people have been able to engage in care and have access to care and resources they didn't have outside of pregnancy. So I'll have some comments about that in a second, but I just kind of want us all to kind of hold that concept for a second, and then switch to this other story on the right of another patient who taught me so much. This individual was experiencing homelessness, had a substance use disorder, had so much trauma, and had been trying to get access services for a very, very long time. She got pregnant, and with her initial prenatal labs, found out she was living with HIV. That then opened up a world of services to her, including housing, a case manager, access to mental health services, and she started engaging in substance use treatment. She did fantastic. She got treatment for her mental health conditions. She got started on her HIV medicines, and that, especially that earlier access to housing, really kicked off her healthcare. And what she said at the end of her pregnancy, as she was leaving the hospital with her baby, was that HIV saved my life. And again, this was, really surprising to me, in that I really never expected, going into this work, that I would hear a phrase like this. And so I wanted us all to pause and, first of all, appreciate the strengths of our programming and appreciate how oftentimes in pregnancy, in HIV care, we can expand our services and stretch and really take care of people in the way that they deserve. And I also want us to think about what's wrong here. Why is it that people need to either get pregnant, be diagnosed with HIV, or have these specific diagnoses in order to access the care that they need and deserve? And why is it that so often, even when people have one of these conditions, their care is so siloed, and we really struggle to, first of all, make sure that it is multidisciplinary integrated care. In addition, our care is often so short-sighted and so emergency-based in the sense of, even when you think in short term, when you think about a pregnancy in the context of someone's life, it's really short. And so why do we kind of beef up these services so quickly and then let them all fall away? What else to think about? This is not the focus of this talk, but especially for people who increase their accesses to services when they're pregnant and then they fall away postpartum. That is really not taking care of the whole individual. That really sends a message to the pregnant person that they, are worth investing in because they are a vessel for carrying a fetus or a child, and that as soon as the baby is outside of them, they're not worth investing in them anymore. So what does that tell to people? What is the messaging we're sending, and how can we change that? And then the last thing I would just say is, all of these stories focus on treatment instead of prevention. We wait for a diagnosis to happen, and then we offer people services, as opposed to thinking about how we can really improve people's overall well-being, to try and prevent some of the outcomes that people have to go through in order to access services. So I'll ask you to kind of carry those questions and thoughts through the rest of this talk, so we can think more about how we can provide more integrated and person-centered services that really focus on the well-being of people over the lifespan, not prioritizing a pregnancy or HIV services over anything else, and really listening and hearing from those individuals, those affected individuals, who are the experts in their bodies, in their experiences and histories, about what they need first and how we should be prioritizing their care. So with that kind of overview, I'm going to zoom in a little bit to what is Team Lily, which is the program that I work with in San Francisco. Big picture, Team Lily is a hospital-based program. We provide multidisciplinary care, trying really hard to provide person-centered, trauma-informed wraparound services to pregnant and postpartum people. Now, for that postpartum piece, I would say we extend that for many years postpartum, and for many people, we kind of continue to take care of them until their next pregnancy, if they get pregnant again, or, as I said, many years into the postpartum period. Our goal, we support people who are experiencing significant barriers to care. So those include experiencing homelessness, substance use disorders, incarceration, significant mental illness, intimate partner violence, anything that is providing a barrier to that individual's accessing traditional four-walled care. Really importantly, we are not a program that requires you to have one specific thing in order to join our clinic. So we are not just a substance use clinic or just a clinic for people with significant mental illness. Rather, anything that kind of blocks or creates a barrier to someone's accessing care, we try to welcome them into care. The flip side is that if someone has one of those structural or social determinants or health conditions, and they are accessing care and have a primary team, we never want to uproot them from their primary team. If that is working for them, that is absolutely the goal, and we want to support that. I just also wanted to highlight our mission, which is bolded on your screen. We strive for a pregnancy, birth, or abortion and postpartum experience that is filled with dignity, that is grounded in autonomy, and that uplifts individual or parenting goals. We are committed to dismantling structural racism and challenging the stigma and discrimination that drives Team Lilly clients' barriers to care, health, and well-being. So here, just trying to emphasize that absolutely we are a clinical program, and we recognize that the reason we exist is because of structural determinants of health, including things like structural racism, discrimination against people who use drugs, et cetera. And we do a lot of advocacy, or we try to do a lot of advocacy around dismantling those barriers so that our program doesn't need to hopefully exist in future. So getting much more specific, who are members of our team? We are, as I said, a multidisciplinary team. We include social workers, navigators, substance use counselors, psychiatrists, therapists, family medicine providers, pediatricians. I'm an OBGYN. And as I mentioned, our goal is to provide this person-centered wraparound care. How do we do that specifically? I'll talk a little bit more about this later in the talk, but we offer something called an open access clinic. We provide transportation to clinics. We provide support around access to housing and food and other immediate needs that people have. And really, we're trying to provide a one-stop shop, integrating substance use treatment, harm reduction, mental health services, pregnancy care, anything else, case management, all in one place, so that people can identify what their needs are and get those met first. We are based in a hospital. Our open access clinic is on Thursdays, but the real work of the program is throughout the week, providing direct outreach to clients, meeting people wherever they're at, partnering really closely with other community organizations, harm reduction organizations, as well as teams like street medicine, public health nursing, and other community organizations. And why did we start? The basic reason, the most kind of clear reason, is because we knew and we saw that our safety net hospital, San Francisco General, which really goes out of its way to try and be a safety net, wasn't meeting people's needs. So I'm going to go a little bit more into that now. Excuse me, 1 second. I wanted to talk, and here's the story part of this talk. I wanted to talk a little bit about really how this program came to be and why. And the reason I wanted to highlight that is because it is so clearly rooted in concepts that came from the HIV care world. And learned from many of you who are on this call today, and thought about how to apply those principles to other populations. So Team Lilly was founded in 2018. And what was happening in San Francisco at 2018, I'm not sure if this is the same or different in your cities, but what we were seeing was, first and foremost, a really incredible uptick in terms of rents in the city, and the housing crisis, which had been around for a long time, was just tremendously escalating. We were seeing so many more people who were unsheltered, meaning they were living on the street in a vehicle, or in a tent. And in addition, that was coupled with fentanyl coming to San Francisco, as well as methamphetamines hitting San Francisco. And so these intersecting crises really led to a group of people who had these overlapping and reinforcing barriers to care. So what did that look like from an obstetrician's perspective or a family birth center's perspective? We were seeing more and more people come into our labor and delivery units who had had no prenatal care or very limited prenatal care. They had showed up to emergency rooms or urgent cares and had gotten, quite frankly, quite inadequate care. They were also carrying tremendous experiences of trauma and mistreatment, specifically at the hands of the healthcare system. And when they came to our birth center, quite frankly, we were really not ready to take care of them. On the top right, you can see our labor and delivery team. And our nursing team, our midwifery and physician team really came to San Francisco General to try and help people. And we recognized that the care we were providing was inadequate. We did not know how to provide adequate addiction care and services, and specifically treating people's withdrawal while they were in labor. People were coming in, they were having their babies, and social work would come visit them on postpartum day 0 right after their birth and say, we're going to call CPS, and that's also known as Child Protective Services. And people would get up and leave very shortly because they had such traumatic experiences in terms of that conversation, or because of traumatic experiences of children being removed from their care in the past. So this was a horrible birthing experience, both for clients and patients in our city, and to be honest, for staff who really kind of came into birthing work with a mission of family building and supporting individuals, and seeing that we were completely failing and really offering a traumatic birth experience. So in this context, I want you to focus on the bubble on the bottom left, which was HIV. So I mentioned I work with this amazing program called HIV, which it was a program and is a program that cares for peripartum and pregnant people, perinatal people who are affected by HIV. And while we were seeing these patients facing significant structural barriers to care, come in and having terrible birthing experiences, through HIV, we were seeing people living with HIV who had those same structural barriers to care. They had significant mental illness, experienced tremendous traumas. They had substance use disorders, and HIV was wrapping around them and taking care of them and helping them have these beautiful birthing experiences. Were they perfect? No, but they absolutely were supporting people's family goals, and the birth center was fully behind them. Just to be honest, it felt like the birth center would roll out the red carpet for these patients, really trying to provide thoughtful, trauma-informed care. And the question we really had on the birth center was, how can we apply those concepts and that work and those strategies that HIV is using for people living with HIV to other populations who do not have HIV? And if we extended that type of work, what would a care program look like? So those were kind of some of the initial founding principles of Team Lily. We then went to the city and said, hey, do you know the number of people in San Francisco who are giving birth with no prenatal care? And the city of San Francisco said, no, we don't know. And then we said to our Department of Public Health, hey, do you know the number of pregnant people who are living with substance use disorders? And the Department of Public Health, again, which is a very well-resourced and very informed and progressive Department of Public Health, said, I'm so sorry, but we don't count those people. And so really what we had found was this was an invisible population that no one was really focusing on, that we were seeing on kind of, in some ways, on the front lines in the birth center, and the city had really not at all begin to address or recognize. And so we started to then instead go to community partners. For example, on the bottom right, this is the homeless outreach team. They are a group of peers who work in San Francisco who do street-based outreach to people on the street and try to bring them resources and connect them to services. And there we learned, oh yeah, there are so many people who are wanting to access prenatal care and pregnancy care, and we just don't know where to send them because no one takes good care of them. And then we talked to organizations like the Homeless Youth Alliance, which is a harm reduction organization in San Francisco that does incredible work with youth and young people around harm reduction related to all different types of harm reduction, but really focuses on substance use and homelessness. And then finally, up on the top left, I don't know how many people on this call have heard of the Nurse Family Partnership, but that's a public health nursing program that works with pregnant people. And traditionally, especially, it's a national program that has been very evidence-based. It's been shown to reduce preterm births, small for gestational age babies, and other obstetrical and pregnancy outcomes. And there was a group of nurses who were receiving referrals about patients and clients who were experiencing homelessness or had significant mental illness or substance use disorders, and were saying, wow, our model is a fantastic model and it's not reaching these clients who are at the highest risk of preterm birth. These clients are at the highest risk of having small babies. Can we think creatively about how to reach those clients? So what I'm trying to say is there were all of these kind of creative thinkers and unfortunately siloed programs who were seeing firsthand the changes in the demographics and the changes in the housing crisis and the substance use in San Francisco, and feeling stuck. And as we began to have conversations with those organizations, we learned so much from them, and were able to modify our initial model of care, which was, again, really rooted in care of people living with HIV, focusing on wraparound services, focusing on low barrier care, focusing on one-stop shops where people could get their needs met, focusing on trauma-informed care, and then infusing these other principles from these other siloed fields to try and develop our program. So I'm going to fast forward quite a bit to tell you a little bit more about who we serve. I've already kind of described the model a little bit. As I said, we have a multidisciplinary team, and I just feel so lucky to work on that team, because what we are able to do is allow people to kind of pick and choose services that feel most important and relevant to them. So who are our clients? These are the people that we serve. About 95% are experiencing homelessness and about a third are unsheltered. 40% have significant mental illness. 40% have Hep C. We're seeing tons and tons and tons of syphilis. 20% have active intimate partner violence. 20% experience incarceration in pregnancy. 80% have substance use disorders, primarily with fentanyl and methamphetamines. And 75% have a prior birth, half of whom who have experienced child removal. And I highlight that because, as I'll mention in a second, what we hear over and over and over again is terror that in pregnancy, people are going to separate them after birth from their child. So what are our goals? First and foremost, we want to provide a perinatal experience that's filled with dignity and grounded in autonomy and uplifts people's individual parenting goals. We want to try and rebuild people's trust in the healthcare system. That's through building relationships, building trust, being reliable partners in people's healthcare. We want to focus on long-term care engagement. This is not just about pregnancy. Yes, we use pregnancy as kind of a lens, as a way to get people in, but we are really not focused just on perinatal outcomes. Our goal is to really help people transition into long-term care. And finally, of course, we want to prevent, diagnose, and treat immediate medical conditions. So I want to take a step back again and think about how the population that we're serving in Team Lily, people experiencing homelessness with significant mental illness, experiencing with substance use disorders, how their experiences may be similar to people living with HIV. And I think in the setting of reproduction, what I have seen are some significant parallels, at least especially to care of pregnant people and people who are interested in reproduction who were living with HIV from 20 years ago. This on the left is a billboard that unfortunately is not very old, from an unnamed state, because I know that this is a national audience, so I don't want to put anybody's state down. But I just want you to take a look at this ad and think about both the direct and subtle messaging that people using drugs might get through this ad. If you're addicted to drugs, get birth control, $200 cash. Stop the cycle of addicted newborns now. Make a tax-deductible donation today. So, and then on the left, you can see their acronym, Children Requiring a Caring Community, CRACK. I could talk for hours about this billboard, and I would so love to hear your thoughts on it as well. But big picture, very directly, this is telling people who are using drugs that you should not get pregnant. You are not fit to parent, and you are a cause of the cycle of addicted newborns. We'll talk about that term, addicted newborns, a little bit later. In addition, this is not just a small organization that is saying this. This is institutional. This is the government, because you can make a tax-deductible donation today to this organization. And everybody from community organizations like this horribly acronymed organization to the government believes that you, people who use drugs, should not parent or have children. And then kind of zooming in, the name of this organization, CRACK, really brings up and refers to that horrible era where the media and medical providers really work together to over-describe the crack epidemic, and describe, for example, very particularly this group of infants who were exposed to cocaine in utero, who were really termed in derogatory ways crack babies. We later learned that the medical information that described these babies as going to have long-term health consequences, going to have learning disabilities, having to have all these issues were completely incorrect. And that really so many of those studies and so much of that messaging was based in bias, discrimination, and racism. And so here we are with this tremendously strong and powerful messaging to people who use drugs. And now I want us to think back to how we took care of people living with HIV, especially 20 years ago, who were thinking about getting pregnant, and how often people were dissuaded from getting pregnant, or told they should not get pregnant, or told you have to get birth control now because you really should not have a baby. There were many medical justifications for those arguments, and yet at the root of it, so much of it was based on, again, that idea of who is fit to parent and who is not fit to parent. I'm really pleased to say that and I'm sure you all know as well, that the HIV community has come so far in terms of changing its messaging around reproduction and parenting and supporting parenting among people affected by HIV. But it has been a long road, and especially a lot of our prior messaging was not dissimilar from this billboard. And I think the same type of messaging can be applied to all of the factors on this screen that you can say for people experiencing homelessness with significant mental illness, people experiencing incarceration. Again, there's this concept that some people are fit to parent and others are not. Which really brings me to the incredibly important topic in theory of reproductive justice, which finally has really infused the HIV care world around reproduction, I think, and that has really moved HIV care in the setting of reproduction forward. I hope everyone is familiar with concepts of reproductive justice, but just as a refresher, reproductive justice is a framework that was developed by Black women to recognize that that there are groups of people who have experienced certain oppressions, specifically in terms of their reproductive experiences, that need to be understood in ways that, first of all, identify intersecting oppressions. For example, racism and housing insecurity and experiences of trauma. And that we need to focus on those experiences to ensure that everyone has a right to have children, to not have children, and parent in safe communities. I could spend a long time talking about reproductive justice, and if you have not read about them, read about these concepts, I'd highly recommend looking at Sister Song, which is the kind of original organization's website that gives a lot more information. And reproductive justice has really informed our HIV care world around ways to approach people living with HIV and their reproduction. What also kind of the leading organization who has recognized that those concepts of reproductive justice, who initially were primarily focused to Black women and women who identify and people who identify as people of color, need to be expanded to HIV and HIV prevention. And the organization Sister Love and Dazon Dixon was really responsible for that, bringing that framework of reproductive justice to sexual justice, expanding it to sexual justice, and which Dazon has defined as the right to sexual health and well-being, recognizing that reproductive and sexual justice specifically includes HIV prevention and PrEP, and includes the right to sex and sexual pleasure free from stigma, shame, and the risk narrative that we know comes up so much in HIV prevention work. So what this organization did was to say, yes, this has to do with reproduction, but it also has to do with reproductive human beings or people of reproductive potential, and recognizing that not everything needs to be focused on childbearing. What I would say is, while reproductive justice and sexual and reproductive justice have done tremendous work in terms of expanding and including the HIV world, they're just starting to expand and include, for example, people with substance use disorders. What are people with substance use disorders' rights to have a child in a safe and healthy community? What about people experiencing homelessness? What does that safe and healthy community look like for people experiencing homelessness? And how can we uplift those goals? And as I mentioned that, I just want to take a pause, because I think all of these concepts feel well and good in theory, and applying them in practice is incredibly challenging. So I just kind of, as we're talking about stories and reflecting, I want to take a moment and ask everyone to think about these questions and how you feel about them in your gut, not to say out loud. First of all, how do you or how do I feel about an unsheltered person who is thrilled to find out she's pregnant and excited to start a family? By an unsheltered person, just as a reminder, that's someone who's staying in a tent, on a vehicle, or in the tent. How does that feel in your body? How does that feel in terms of your emotions, in terms of, oh, this is really exciting, I want to be excited with this person, or I have some hesitations? Second of all, how do I feel about a pregnant person who has had 4 other kids who are not in their care? This individual injects fentanyl, declines treatment for their opioid use disorder, and states that they plan to parent. Okay. And then our third kind of reflective question, and again, say this to yourself, please. How do I feel about a reproductive age person living with HIV who's declining HIV treatment, who also is declining contraception and states they're trying to get pregnant? So again, the concepts of reproductive and sexual reproductive justice would encourage us to embrace these individuals and uplift their care. And I think it's really important for us to be honest with ourselves that for many of us, the feeling that these types of situation evokes is not necessarily one of let's get to work. It can be of wishing that something different. It can be of like, really, this is not the right time. This is not the right moment. And all of those feelings are normal and natural. And our patients and clients feel those feelings when we have them. even if we reflect on them, even if we try to suppress them, they experience that in the way that we provide care, and the way that we talk to people. And what that leads to is they're knowing that we don't want to take care of them, and they're knowing that this is not a safe place to receive care, and that they need to go elsewhere. Coupled with that, as I said, the kind of biggest underlying themes of our Team Lily patients that we found over time actually isn't their substance use. It's not their housing. It's this fear, this terror that you as a healthcare provider or a member of the healthcare team are going to take my baby, or the hospital is going to take my baby. This fear comes from either personal experience, from stories in people's communities, from relatives, and is one of the hardest barriers to care to overcome. And how do we start to approach that? Certainly, again, going back to what we know from the world of HIV care, is using trauma-informed care principles. You all, as people who work in the field of HIV, I think the HIV field really informed so much the way we think about trauma-informed care, how we build safety in relationships, how we always think about providing choice to individuals, not just giving them one recommendation, how we collaborate with people with health decisions, how we focus very specifically on trust building, and very specifically on building people's skills in order to be able to navigate so many different arenas, including the healthcare system, on their own. And yet, while we have those principles, getting very granular and down to experiences that I know many of you have had, this is often what our care settings look like. On the right, we have a client who might be thinking and worrying about, where am I going to sleep tonight? I really need to charge my phone. I hope my stuff is still there when I get back. And on the left, we have a busy clinician who has their own agenda that does not overlap at all with the client's. And providing, there is no room in this scenario, or it's very hard to find room in this scenario for safety, for collaboration, for trust building, due to all of the structural pieces that are affecting both of these individuals. So how can we get around that? Our approach at Team Lily is to first and foremost meet people where they are, to offer a consistent care team, that communicates across silos. We focus very, very much on listening for and prioritizing individuals' priorities, trusting her and them in terms of what we need to work on first. And I'll tell a story about that in a moment. We try really hard to offer information and prevention options to everyone without needing a disclosure, specifically in terms of PrEP and HIV prevention. That's one of the big ones that we try to talk to everybody about. And again, trying to provide choices wherever possible. We have a kind of saying in our group that if we can only think of one option for this client, then we are not thinking creatively enough. There are always other options. When we think more about harm reduction, in particular, we can come up with different ways to approach whatever clinical scenario we're thinking of, and come up with different options for this client. In addition, in terms of our care team structure and approach, this we also learned very directly from the field of HIV, which is that there's always a group of people who come into care regularly, and we're talking about them when we're caring for them. And then there's a group of people that don't show up, even for this lower barrier goal program that's trying to extend services to people who aren't making it into care. There's still going to be those people who are lost to follow up. And so very briefly, we developed this weekly call that was designed exactly from the field of HIV in San Francisco, who had a multidisciplinary call of community organizations and care providers who were trying to do outreach to people living with HIV who are not in care. And we developed those same concepts and applied them to pregnant people who are not in care. And we developed this multidisciplinary group that was including pregnancy care providers, navigators, social workers, harm reduction organizations, substance use treatment programs, public health nursing, and then really importantly, the Department of Public Health's STD managers, because we recognized that there was this significant overlap between the people we were trying to reach and who very specifically in San Francisco was affected by syphilis in our city. Syphilis had become increasingly common, in particular among people experiencing homelessness and with substance use disorders. And San Francisco went from having 0 congenital syphilis cases to 3, 4, 5, 6, 7. And it was ridiculous in such a small city that had eliminated congenital syphilis for so long. And so the Department of Public Health and DIS workers very specifically were very interested in working with us, both to try again to work on prevention and treatment of syphilis, as well as recognizing that when they have people, they can do more to link those people to pregnancy care and services, and specifically programs like Team Lily. So what does that loss to follow-up call look like? A public health nurse facilitates it. We talk about people who are not in care, known to be pregnant, and experience significant barriers to care. And we strategize about how, in a trauma-informed way, in a coordinated way across our silos of care, to help get them into care. And specifically, in terms of the HIV prevention lens and the syphilis lens, to get them testing, to get them treatment, and to offer them prevention services. We also focus on pregnant people who are diagnosed with syphilis and not yet treated. And finally, people who are treated with syphilis who require additional support in terms of getting into wraparound services. And the goal of that call is to, across these different organizations that are so frequently siloed, to coordinate plans for treatment, testing and treatment, and perinatal care and engagement. So I wanted to, and I'm going to wrap up very soon, I promise. I wanted to take a moment to tell a story about Jackie, who's another client who taught me so much. She was pregnant, living in a tent on the street and using methamphetamines daily. She was using meth primarily to stay awake at night, to keep herself safe. Through a street outreach team, she was diagnosed with syphilis, gonorrhea, and chlamydia. We offered her PEP and PrEP, and talked a lot about HIV prevention strategies. And she said, I just need to focus on housing right now. Everything else will fall into place, even my recovery. And we heard that, and it was paining my heart. I just so wanted her to start on some PEP, and I wanted to start talking about her methamphetamine use. But I was able to kind of stop that. Our navigator did an amazing job getting her into housing. And exactly like Jackie said would happen, everything else did fall into place. She was able to stop using methamphetamines. She was not in the same places and experiences that required her to have so many exposures. She didn't need PrEP or PEP anymore now that she had housing, and she was able to get into treatment, leave the hospital with her baby parent, and now she is an incredible substance use counselor. So just to say, this is an example of following people's lead about what their priorities are and what the right prevention strategy is, and then B, recognizing that pills like PrEP or even injections are not a silver bullet. And rather, we have known for so long that social and structural determinants of health drive HIV diagnoses, especially in cisgender women. And so therefore, we need to address those health determinants. And when we do that, that actually is a really important form of HIV prevention. In Jackie's case, that was around housing. For other people, that may be around food or transportation resources. For other people, it might be as simple or not as simple as rebuilding trust in the healthcare system so that they can access person-centered trauma-informed care, and also have access to low barrier services to get the treatment and the prevention care plans that they deserve. So I do think part of this work is expanding our understanding of prevention services and trying to include a structural lens. In addition, we absolutely do offer PEP and PrEP to all of our patients. And I have to be honest, so many patients and clients decline. They say they can't take a daily pill right now. doing the labs for the injection is too complicated, that they have other priorities, and that there's not that much HIV in San Francisco. What they're really worried about is syphilis. And so again, we have ongoing conversations. And again, we really try to have these conversations with everyone, not doing it in a stigmatizing way and requiring disclosure first. I think the structural barriers and the structural roots of people's vulnerability to things like HIV are so profound. Patients and clients know that, and they want to address those other pieces first. I want to transition because a lot of that was related to information that we learned and strategies we learned from the HIV community, to very briefly talking a little bit about what we've learned from the care of people experiencing homelessness in that world. And very specifically, there's a type of clinic that we developed, which is called an open access clinic. Open access clinics are a form of low barrier services that have been tremendously helpful for us. What that means is that you have a group of people and a clinic panel that has people's names on a list, but the times do not mean anything. And most of those people are going to be navigated into care by community partners with a range from things like a navigator going and showing up at someone's tent and sitting there from 3 hours and literally walking them and navigating through the city and through the hospital to get to clinic in order to make it through all of those challenging places where people often get turned away. So we have a range from that to people who just literally need a text and a Lyft ride to get them to clinic. And the difference in many ways, it is a drop-in clinic. People can show up even if they're not on the list. We just add them to the list. But the difference between an emergency room and an ER is that they're always going to see the same team of providers. We are always there. We know their story. They don't have to tell it over again. And that has facilitated tremendous attendance in our clinic. Part of the reason my voice is hoarse is because I was in clinic yesterday from 9 to about 8 o'clock at night, and we saw so many patients. One of the questions about our program at the beginning was, would patients come into care? And we have learned resoundingly, absolutely yes, when you partner with community organizations, when you have low barrier services, when you have open access clinics. So that's one piece of our low barrier care that we've learned from the homelessness world, because they really founded that concept of the open access clinic. We also try to bring testing and treatment to wherever people are. We bring syphilis treatment, STI treatment, obviously testing, and specifically point of care testing. We also bring prenatal care to wherever people are. So we can bring top daptones into the field. We can check people's uterine height or fundal height. We can bring maternity clothes or pregnancy clothes to try and build trust and work as a bridge to eventually getting them into clinic care. And similarly, we can bring substance use treatment to wherever people are. And finally, I'm going to wrap up by just saying that, oh my goodness, I apologize for the time, that our work is really infused by concepts of harm reduction. San Francisco AIDS Foundation has my favorite definition of harm reduction, which is harm reduction is a way to meet people where they're at without requiring you to meet certain conditions in order to maintain your health. It's safety your way. And I would modify that a tiny bit in saying that it's not that you have to necessarily meet certain conditions. It also doesn't mean you have to have certain conditions. So you don't have to be living with HIV. You don't have to have a substance use disorder. You just bring yourself as you are, and we will meet you where you are to try and match your goals with the services that we have. The principles of harm reduction I love are put out there by the National Harm Reduction Coalition. I'm going to leave you to read those. And I'm going to move on really quickly to say how practically we put those into our work that has really been formed by an incredible harm reductionist in San Francisco, Mary Howe, who founded the Homeless Youth Alliance. She says to really focus on the importance of language, Be yourself. Don't make assumptions. I love this one. Only ask questions if they have a purpose. If you are a healthcare provider or an outreach worker and you are screening someone for some condition and you can't do anything about that condition, don't ask the question, because you're kind of building up hope in that individual that you're going to be able to do something about it, and you are going to break their trust because you actually don't have those resources. You're going to focus on building create a safe space, and it's really our responsibility to do that. We're going to earn trust with patience and consistency, and very importantly, honor the priorities and decisions of individuals, recognizing that they as clients are the experts in their care, and never assume that we're done learning. The harm reduction community and the HIV community, again, here's a beautiful moment of intersection, have worked so hard to think about language. Here is some of the language applied to substance use that I wanted to highlight. First and foremost, people often talk about clean or dirty urine, or they are clean or not, or dirty, referring to substance use. Again, that is a derogatory term. People are not clean or dirty if they have drugs in their body. Urine is not clean or dirty if there are drugs in it. So we can talk about the presence of drugs or not having drugs. In addition, we also talk often about drug habits or drugs being a choice. And when you talk to people who have substance use disorders or addiction, they say, this is not a choice. Part of my addictions, part of my use disorder is that I feel compelled. I don't have a choice, and I wish I had a choice. So we can be much better and more clinical in our language, talking about substance use disorders and drugs that people use. How can we integrate harm reduction practices into our care? We provide a lot of traditional ways of harm reduction: needles, wound care, saline, fentanyl test strips. We also can recommend changes around the mode of people using drugs, from going from injecting to smoking. We talk a lot about Narcan, both for adults and to kids, because kids do sometimes get into adults' drug supplies, and we want to make sure people know how to take care of their loved ones. We provide lock boxes to everyone who have children in their home. We talk a lot about the safety of breastfeeding and how, if you do have a relapse and return to use, how you can pump and discard your milk. And we focus very importantly, just like in the HIV world, normalizing return to the use in the postpartum period, just how we try to normalize that people often stop their HIV meds or get off of their HIV meds in the postpartum period. Normalizing that so we can create a safe place for people to come when they are struggling, so we can strategize and plan for it, and try to come up with a strategy to get over it. So I'm just going to stop there and go to our takeaways, because I've spent so much time. Again, I apologize. And these are my closing thoughts. Big picture, we're trying to use the same principles that served you and your clients in HIV care and treatment of to apply those to treatment of substance use disorders. We're trying to provide low barrier services, and we're trying to integrate principles of harm reduction into our work, kind of infusing all of these tremendous concepts to provide care that breaks down silos, that crosses reproductive and sexual health, including substance use disorders, and mental illness, and housing for people experiencing housing, to really try and uplift individuals as the experts in their care, bring them the services that they need, partner with them to try and provide person-centered services. So with that, I will stop. I apologize for going so far over. I can stay for a couple of minutes afterwards for questions, and I neglected. I'm going to go back one more time to leave my email on the screen in case people have questions they want to contact me afterwards. Thank you so much. Actually, I'll put it in the chat.
Thank you so much for that insightful presentation, Dr. Simon. There's a lot of engagement in the chat regarding your presentation, so we do appreciate that. I will say, before we get into the Q&A, there are a few questions in the Q&A, and I just want to say that Ashley did add the link to the evaluation in the chat. If you are If you're not able to stay for the remaining part of this session, do not worry. The CE requirement of 60% only applies to the scheduled time, but we will be recording and sharing this session afterwards, so you can always catch up on the questions that assignment answers. So I do want to go into a comment that was added, and then we'll go into the questions. Let me just go up. There was one comment that said that this person is a psychologist from Michigan who went to grad school in San Francisco. As part of the harm reduction strategy, they tried to get local LGBTQ plus organizations and businesses to display the DoxyPEP posters without any luck. So bravo to San Francisco for doing so. So just wanted to highlight that. Okay, and then there was another question that you had showed the website. You were talking a lot about Project Hive, and you had showed the website. Unfortunately, when going onto that URL, it's not live. I don't know if you're familiar. Is that a project still active? So it just maybe something with that. Okay, so we did try the link. Some of us put that link. So I don't know. Just perhaps it's just down for right now, and people can try again later.
I'll put in the Hive link right now.
Okay, perfect. Thank you so much. Okay, so in terms of questions, and we'll really get into it, what would you like to see come back from the early years of HIV care?
What would I like to see come back? Is that what you said?
Yes.
Oh, such an interesting question. Come back. You know, I think first and foremost, when I was, I don't know how early you're talking, but I'll talk about early in my experience. When I was a trainee, when people were living with HIV came onto the unit to have a baby, there were multidisciplinary teams and meetings and conversations about how to really provide this person with the best care, with the most exceptional care, recognizing that people had experienced such crummy healthcare experiences in the past. And again, I recognize that this was like later in the early era of HIV. That was not true very early on. But it was a big part of my training, and it influenced me tremendously. And I was just so impressed how places like birth centers would come together to provide compassionate and thoughtful care to these individuals. And I think what we have tried to do is to take those concepts and then apply them to people who have substance use disorders, who are experiencing homelessness. And we've come a long way, and we still have a long way to go. Because we continue to have those biases and those frustrations, and people continue to be triggered, in our clinical environments. And so what I wish to come back is that same kind of deep commitment to each of these individuals, recognizing that in some ways this is an equity issue. This is not about providing exactly the same care to everyone. This is recognizing that for so many reasons, this individual in front of us is in this scenario because we as a healthcare system have harmed them. And so now we have the responsibility to step up, to roll out the red carpet, to provide the best care in our care settings, whether that be labor and delivery or anywhere else. And I think the field of HIV really put that concept forward, and through advocates and individuals affected by HIV telling their stories, and through clinicians led the way that type of equity-based care was important. And so I think as HIV care has become more straightforward in some ways, and as people have, it's been kind of often made into routine care, into primary care, some of those concepts have gone away. And I hope that we can still continue to apply them to anybody who has been in so many ways harmed by the healthcare system, as people living with HIV were for so many years, and as people with substance use disorders continue to be.
Thank you. Is sobriety or substance use disorder treatment, MAT, a requirement for Team Lilly patients, clients?
Absolutely not. Nope. So we work with tons of people who are using throughout their pregnancy. And one of our goals is care engagement wherever you are at. And through those conversations, I had one client who was injecting drugs and really working on transitioning to smoking instead of injecting. And but really that process, that ritual of injecting was very important to them. So I would give them weekly saline and clean needle supplies so that they could inject saline and smoke their drugs, and slowly over time be able to stop injecting. And that was, I don't know how helpful that was to the client, but I do think it really helped build trust in terms of us understanding each other, that I cared about them as a person wherever they were at, giving them maternity clothes, ordering them a breast pump, talking about their other needs. And yeah, I think there's so many different ways to listen to people and meet them where they're at. And so, yes, absolutely. We welcome people who are still using drugs into our care.
Fantastic. So this is a really great program, but who is paying for the open access clinic? The city or county of San Francisco?
Yep. So we started as a grant-based program. We had 20 million, I'm sure so many organizations on this call know this, 20 million tiny grants that were impossible to manage and all had very long write-ups that we were doing after clinic. Regardless, so we started because the city said, we don't think you can do this. We don't think that this is going to work out. So from that, over about 4 years, we were able to show that we had patients, and then we were able to show that we could bill for their care through Medi-Cal. I am privileged to live in California, so we have healthcare for all pregnant people, and certainly our clinical services, we were generating revenue from. And then in the past 2 years, California has had this incredible overhaul of Medi-Cal that's called CalAIM. And to make a very long story short, they are now providing reimbursement for navigation and social work services. So we were able to go to the city and say, hey, we are bringing in revenue. Now you need to compensate us to pay for our time. So just in the last year, we got Department of Public Health funding that basically kind of showed that we are kind of net zero in terms of our funding. So yes, we are now finally a city program, but it was a struggle to get there.
Well, thank you for that. So I see that there are no additional questions in the Q&A, and there are no virtual hands raised. So once again, I want to thank Dr. Simon for that amazing presentation and all those who participated today. So we will follow up through email with the link to the PDF of the slides as well as the recording, and we will also send out the evaluation. So if you haven't had the opportunity to fill out the evaluation, we'll send out that link. And Dr. Simon, when you get a chance, can you add that link for Hive in the chat? Again, I tried to look through it through Google, so again, I don't know if just perhaps that website is down, but if you can send that link, we appreciate that.
I'm so sorry I couldn't talk and find it at the same time, but I will absolutely send it out. I just am not that coordinated.
No, that's okay. And we can always include that link in the post webinar email so that everyone can receive it. So with that, so we just want to remind everyone that the next session in the series will be Triply Diagnosed on August 2nd, on Friday, August 2nd at 12 p.m. Eastern Time. That will be presented by Dr. Francine Cornos. We look forward to your participation and we wish everyone a wonderful day and weekend. Thank you, everyone.
Thank you, everybody.